Hi, this is Terry Kuti, founder and director of deepseafoundation.org. We provide these video interviews and podcast as a resource to guide you in your decision process for surgery if you have been affected by breast cancer. However, we also provide them for other plastic surgeons who might learn techniques, protocols, and best practices from our guests. You can watch the video on the educational YouTube channel over at Deep Sea Foundation, or you can listen to the Deep Sea Journey podcast on Spotify, Libsyn, Apple Podcast, and Amazon Music. We're going to discuss scars today and several topics related to scars. So it goes without saying that anyone that has any type of surgery is going to have some kind of scar. There's a mechanism to how scars heal. In plastic surgery, if you think of the Greek word plastikos, it means to shape or mold. Scars are significant consideration then in plastic surgery. I invited an expert in the field to share his expertise on the topic. Let me introduce him now. I'm speaking with my guest, Dr. Andrew Gassman, who joined PRMA in San Antonio, Texas in 2021, and that stands for Plastic Reconstructive Microsurgical Associates. Dr. Gassman completed his plastic and reconstructive surgery residency at UCLA David Geffen School of Medicine in Los Angeles, California, and a general surgery residency as Chief of Surgical Resident Education at Loyola Medical Center in Maywood, Illinois. Following his residency, Dr. Gassman completed his fellowship in breast reconstructive microsurgery with a subspecialty in facial reanimation at UTSW Department of Plastic and Reconstructive Surgery in Dallas, Texas. Dr. Gassman and his team of surgeons at PRMA practice the co-surgeon model, and that means that patients who are undergoing autologous breast reconstruction will have two board-certified microsurgeons in the OR at the time of their reconstructive surgery. Now, PRMA is also a member of the IFAR, that stands for the Institute for Advanced Reconstruction network of surgeons. And what they do, what the IFAR network does, is collaborate with other surgeons across the country to improve patient safety, care, and outcomes. Dr. Gassman, thanks for joining me again because, I went and looked. We knocked out a pretty cool podcast on social media last year. I'll have to put that in the show notes, but thanks for joining me again to talk about this important topic. How are you
No,
doing?
my pleasure. My pleasure.
Are you doing well?
Doing well. Doing well. Busy. It's
Y-
and taking care of a lot of great people.
I know you are. Well, let's go ahead and dive into this topic because, um, we were chatting before we started recording, and on my Facebook group, there is a lot of discussion about scars. So how about if we just start out about where scars can be placed? Because, we always think about DIEP flap, but there's other types of breast reconstruction. So do you want to start out with scar placement, where it might be on the body?
Sure, that sounds great.
Mhm.
Well, thank you for having me. And as far as scars, as a plastic surgeon, they're very important. Very important to us in a consideration because these are the marks that a patient's going to carry with them for their lives.
Yeah.
And we are very conscientious as far as where they are, the extent of them, and what's entailed. Now, as far as placement, I usually say to folks that anywhere in the body that people commonly remove tissue for a contouring reason or some other, generous area of the body that we're able to remove tissue, that's generally where the scar is going to be.
Mm-hmm.
We try and use as many of our techniques as possible to hide those scars and make them as inconspicuous as possible. Most people know the deep flap and they know that's most akin to an abdominoplasty, but that surgery, like some other body contouring procedures and breast reconstruction, flaps kind of have different overall objectives. Excuse me. Um, a deep flap really has to prioritize where the blood vessels of the body are, as with any microsurgical breast reconstruction, and where those individual small perforating vessels exist really determines the overall scar placement and the design.
Mm-hmm.
Once that's been established, we work around the patient's other factors, such as how stretchy or pliable their tissue is, and a few other anatomic factors to really help disguise or hide the scars. Typical donor sites for breast reconstruction, besides the abdominal area, include the inner thigh, which could be what we call with a tug flap, the inner to posterior thigh, which we commonly describe as a pap flap, the outer thigh or the lateral thigh, and that's the lateral thigh flap, as well as several other flaps that exist on the thigh on the outer aspect as well. Other donor sites can also include areas of the buttocks, whether it's in the lower portion, such as an inferior gluteal artery perforator, or the upper end, the superior gluteal artery perforator, as well as scars that extend into the back proper, such as a lumbar artery perforator, or even any kind of perforating vessel that comes from the thoracodorsal blood vessel. As you can tell, and this is more for the patients in the audience, any of these unique, unusual names are basically the areas that are named after the blood vessel that we're curious about and the blood vessel that we're searching for when we're doing these reconstructions.
And what's interesting to me, and I think comes to mind, you could have two patients side by side who might decide on a pap flap. You could have two patients side by side who might be considering a deep flap, and those blood vessels are going to be potentially in different areas of those areas that you take from, which would translate into where the scars are placed, correct?
That's true. Yeah, the blood vessels follow a loose general plan, if you will. And
Right.
I always describe these areas as essentially zip codes of the body. But where they actually specifically exit the body and go into the fatty tissue that we're after really is variable. It just is unique to people as, say, fingerprints.
Yeah.
And we have to find those and unlock that unique combination from person to person. And if we just went and did a standard cut and a standard design, we would lose out and actually lead to additional complication, both in the flap that we move and then also in the donor site that has to heal. So very careful planning goes into both sides.
So this is a good time to segue. I'm going to talk about wound healing and wound care in a minute, but I'm going to jump forward then to scar management, because there's some new techniques that you wanted to talk about. There's some, and I guess what I'm thinking about is the coloration, laxity, previous radiation. We talked about it earlier. So let's talk a little bit about scar management when you are performing the surgery.
Sure. So during the surgery, during healing, there's really three elements, three phases. There's the inflammatory phase that happens the day of and right around the actual time in the hospital. A proliferative phase, and that's the true active healing component that happens during recuperation over the following weeks. And then over a lifetime, you're talking about maturation, and that's remodeling. Treatments that we can do really affect what happens at unique elements along those ways. So during the inflammatory phase, making sure that we have done everything we can to either limit inflammation, but yet have an appropriate reaction to healing are all things that can be done. So this is good surgical technique. This is good surgical planning. We have to put in a whole series of sutures, not only in the skin, but in the area below the skin that really help take tension off that closure. Any skin closure that is drum tight is going to experience a significant amount of tension. And tension is really important in terms of what leads to, say, a wide scar. And I would say characteristically, when we are robbing a lot of tissue from one area, we're asking that area to close with some degree of tension so that we can maximize the benefit of where that's going. And so these are these sort of conflicting judgments that have to be done in terms of what we deal with, what we leave behind and what we move. Appropriately planning the donor site, the design, and how we close that is all important. More often than not, incisions are closed primarily, in which the incision is closed to a nice fine line, but there are other adjuncts that we can add that help take tension off that closure. Sometimes that can be in the form of a vacuum device that's placed on a closed incision. The vacuum device is meant to essentially help facilitate taking tension off that closure. It also creates minor manipulations within what's called the extracellular matrix of the body, which is the tissue between the tissue, if you will, what makes us up that's in between our cells. And having a negative pressure in that area has been shown to stimulate and accentuate our healing. During that initial time period, there's a number of factors that your body is secreting that really stimulates all the machinery in your body to heal, to come to order, to essentially come and actually activate the healing process. It even starts with when people clot. The blood and blood clots that we have are really dynamic, elements of our body that release growth factors that stimulate very important healing components. Like the platelets we have platelet-derived growth factor, it's a mouthful, that actually stimulates fibroblasts and other important mediators and cells in our body to kind of come and actually do the mending that is required. And that then is what stimulates all the proliferative phase to really initiate once the fibroblasts and other cellular structures are in place. I don't know if I'm going too far down the whole biology of this, but it's definitely, I think, kind of interesting to me in terms of where it eventually goes.
No, not for me, Dr. Gassman. And I do think there are patients who like hearing this, but number two, hopefully we've got some surgeons out there listening as well. And it's certainly not too detailed or going down the rabbit hole for me, because, I think to myself, if I was sitting in front of you right now and having a consult, I personally would want to know these things. I might be taking notes, which I have been, but no, please continue.
Okay. Well, there are a number of newer sort of innovations that allow us to kind of intervene at each one of these points. So, for example, in that inflammatory phase, fresh out of the operating room, so to say, using negative pressure devices, using devices that help with closure, specific devices that, like even unique sutures that have that are knotless, that allow us to achieve closure, but essentially edit out minor disturbances during the healing process. These are conscious decisions by the surgeon that help impact the final scar quality. A quick note on the knot component. The sutures that we use more often than not are absorbable. And that absorbable material dissolves over the course of weeks to months. the studies that were done to look at the density and how quickly this material dissolves is rated based on the suture itself, but not necessarily a knotted suture.
Hmm.
And the feel of this material is very similar to like fishing line or something along that line.
Mm-hmm.
And when the knot is created, it becomes much more dense
Mm-hmm.
and stiff. And as tissue softens and heals, then those little sutures can erode, and we call it spitting. But that becomes a secondary inflammatory event weeks down the road. And in that little element alone, besides essentially destabilizing the scar as it's maturing, creates another element of inflammation, which essentially restarts the healing process. So conscientious decisions where we use sutures and techniques that limits those sorts of events are critical. And you don't have to use knotless suture techniques. It can come down to simply a technique and how it's done. And it's very surgeon specific, so I don't want to speak totally out of turn.
Well,
Now, there are other modalities that can
yeah.
be used to kind of help reinvigorate the proliferative phase. And I had mentioned platelet-derived growth factor. There are a number of modalities now where we can actually amplify growth factor mediation in terms of, and these are, I want to say somewhat experimental, but they are newer modalities in which we are using um, platelet-enriched plasma or fibrin products that come from a patient's own body. But those are adjuncts where we're actually trying to help foster healing within this area, but definitely newer modalities.
Sometimes known as PRP, the yeah.
Yeah, so exactly, PRP, and then actually newer where that turns into a fibrin plug. Sometimes people see that as well as a PRF, but
Mm.
it's within the regenerative realm. It's growing highly. I would say in some respects it can be controversial depending on people's approach, but has definite benefit. Um, yeah, yeah.
Very
Um,
interesting. I think of using the body's own regenerative system. I mean, what are we doing in breast cancer now? There's immunotherapy, right?
mhm.
So in healing, in wound healing and surgery, makes complete sense to me, and I'm glad you talked about it. So you did talk about the wound, the need for wound vacs and the benefits of those. Who might need that? Because I don't think every patient wakes up with a wound vac, and certainly, again, patient specific. There's plastic surgeons across the world. Some use it, some don't. But who
Mhm.
in your practice, who might be someone who's a higher candidate for a wound vac, if I'm
Mhm.
phrasing my question correctly?
Yeah, who would benefit, from that? Basically, anyone that is at a high risk for a wound complication.
Mm,
Anybody that could potentially run into difficulty with keeping their wounds closed, let alone initiating the healing process. And typically, the factors that go into that would be an infection,
mm,
which is, I think, can be obvious. Sometimes it's not. Some people will actually have folds in their skin where they're retaining bacteria. Hygiene's not always, primary. There are people that have deficiencies in certain vitamins and critical compounds that you need for protein manufacturing development.
mm,
If there's chronic use of medications like steroids or anything that actually turn down both inflammation
mm.
and wound healing. And that sort of, couples along with when people talk about, I guess you would call them more traditional chemotherapeutic agents
Yeah.
that have some reduction in healing capacity and is the primary reason why there's usually a period of weeks between completion of one therapy, a surgery, and then starting a therapy after a surgery.
Mm,
We had already talked about, tension, which can lead to some actual ischemia at the skin level.
Hmm.
Um,
Ischemia, Dr. Gassman, meaning for the
Oh,
listeners that
yeah,
might
a
not know.
lack of sufficient blood flow.
Yeah.
So if an incision's closed very tightly, the incision line and the skin there is actually subjected to a fair amount of shearing force that
Mm,
actually that force can pinch
mm.
the tiny blood vessels that go through the skin level.
Great
Um,
explanation.
Yeah, if there was ionizing radiation, so that would be more, I guess, prevalent in individuals that have had radiation, say with a prior lumpectomy or
Hmm.
breast conservation that then convert to a mastectomy in time,
Hmm.
or some other area where there was like maybe a delayed reconstruction where there was a substantial amount of radiation, um, and then healing those areas. And then diabetes and how well glucose is controlled, that's an important reason as well. But all these factors, generally speaking, are things that should make both the patient and the surgeon or physician, wherever they are in the care profile, really take pause and think and plan. And putting that together, I think having these newer modalities in the armamentarium available um, is really just good planning.
Oh, I would 100%. You know, it's interesting. Someone recently asked me, and I don't know which video they were referring to be honest. They asked me about scars and healing. I believe it was a question in relationship to someone who has maybe they're immunocompromised through lupus, or
Mhm.
I know that there's some, and I can't come up with the name right now, but there's some condition of the skin that makes it difficult for patients to heal properly. I'm not a surgeon. I'm not coming up with the word right now. You know what I'm talking about?
There's many. I mean, there's
Yeah.
like yeah, there's many.
Hmm.
Yeah.
So they might benefit from then the wound healing as well, or the wound vac, sorry, as well.
Yeah, and there are multiple strategies that come
Hmm.
into mind, and I think it's important that I just don't want patients to fixate on a specific product or any one thing.
Right.
It's more like a whole strategy and a philosophy on how to kind of approach the complex problem. And someone that has difficulty healing. And we fortunately or unfortunately, I don't know, it depends on your point of view, see this quite often where people are turned down because they just don't have, the bandwidth locally to kind of contend with these complex issues. And there are also unforeseen circumstances. There are people that have biologic risks for unusual presentations of healing that they didn't know. Like there's this unique condition called pyoderma gangrenosum, and I know it sounds like something out of Harry Potter or something, but it's it's an autoimmune condition that actually surgery makes it worse. And it looks, for all intents and purpose, like a infectious process, like a necrotizing fasciitis. And if you're not fully aware and it's not in your mindset, you can really run into a lot of trouble. And so having those sort of backups and plans and a wider field view, I think is super important.
Yeah. I think earlier I said, when I asked you the question, I said immune deficiency, and I did mean, so I'm self-correcting, autoimmune,
Mhm.
conditions or something going on there. Um, so let's roll into scar management in terms of after.
Mhm.
Well, you've talked about, the whole process here, but I'm talking more specifically about some products that patients talk about often.
Mhm.
There's all kinds, scar tape, silicone sheets, um, scar cream that I know one of your surgeons at PRMA has developed the invisible scar cream with silicone in it, but there's lots of products. Can you,
Mhm.
yeah, let's talk about that for just a second, if you would.
Sure. So, at that point, you're talking about going from the proliferative phase to remodeling, and that's something where the incision has mended to almost near strength of where it had been prior to the actual cut.
Mm,
And at that point, there's sort of this constant flux of biologic factors and proteins constantly shifting back and forth. I guess I've always thought of it as kind of beaches where the sand's always shifting in time. The beach is there, but it's constantly changing.
mhm,
And what you can do with that opportunity and using that analogy is if depending on how you are affecting the environment around it will determine whether or not that beach erodes or it grows. And the management of how we deal with scars during that time period is sort of our point there. So silicone, whether it be compressive in terms of tape, which generally has some of the best data, or
mhm,
the silicone creams themselves, is meant to be compressive, may even have an ischemic component to it,
mm,
but it's meant to limit that scar progressing and
mm,
getting bigger. And there's essentially two major dimensions of growth of a scar can either be elevated in height off the skin or
mm,
grow in width from where the center of that cut had been.
mhm.
And we're trying to prevent both those from happening.
Yeah.
There's just some clear definitions whether or not we're talking about keloids or hypertrophic scar, and it determines by like the height and also the amount of invasion into local tissue. But all these factors are meant to improve that. Fortunately, in rare occasions, do we actually have to reoperate solely for the scar itself
Mhm.
because there are so many good therapies now.
Yeah. It's interesting. I sometimes think of a scar as almost a living thing, the way
Mhm.
yeah. Um, okay, so I hear patients talking about scar revision at
Mhm.
phase two, lowering the scars, when they request that, cleaning up the line. Do you want to touch on that a little bit? Although you have mentioned some of that, but for
Sure.
phase two
Yeah,
specifically.
so commonly in phase two, there's a few contour related issues that we're addressing. At the same time, in order to technically do that, the scar itself is excised and redone. So the one of my least favorite words in all of this field is the dog ears. But basically, the prominent area, which is essentially a geometry problem of the corners, when we excise that, that's an area which, because it is the corner of the incision, is generally has less tension across it, will end up quite thin in time, and that helps with that contour issue, and then potentially flattens that. Lowering the center of the incision or bringing down the area in the middle is commonly associated when there is a contour issue, whether it be abdominal skin flap above or the suprapubic area below,
Mhm.
or if there was a wound healing issue where the skin had mended together
Mhm.
in that plane, or it actually healed down to the abdominal wall and became a tethering point underneath. Because
Interesting.
scars heal in multiple directions,
Yeah.
not just in one plane, but in multiple planes. And so that revision will allow us to essentially redo that. Now, one of the reasons why I think that makes a lot of sense to do a revision in that setting is that compared to the initial operation, the revision surgery typically is not as long and
Mhm.
is less inflammatory in terms of all the other events that are happening in the body
Yeah.
with less overall inflammation, potentially less swelling. um, there is less cues for the body to develop an excessively inflammatory state that would lead to worse scarring potentially.
Hmm.
And essentially taking the easier shot, if you will, is a good chance to give yourself the best option for the cleanest, nicest, thinnest scar. Because the scar, like you said, is going to happen,
Yeah.
but we want to make sure we plan and optimize for what that looks like.
So interesting what you say about the inflammatory response too, because that can just kick up so many things. So I'm really glad you brought up that point. This one might be a tough one to tackle, Dr. Gassman, but
Okay.
as we wrap up here, I think that scars beyond their physical component, they carry a very emotional component for patients. Do you want
Hmm.
to speak about what this is just your personal thoughts on this? Because I certainly hear a lot of women talk about it. You see, you know, quotes and photos and everything on scars. I mean, what are your thoughts on that, and what do you deal with the emotional component of scars at your practice?
Yeah. Um, Scars are divisive, and they they either bring out the worst in how someone feels or the best.
Yeah,
Um, and there are people that feel that they are essentially a badge of honor, and they're proud by what they see. And even though it's not perfect or whatever someone else may think about them, they're proud of them. And it gives them a sense and a marking of their history. I would say it's akin to people that get tattoos around major events or and want to have that as a reminder and their own sort of pride over their history, whether it be happy or sad.
hmm,
There are other people that you see those things and it's a constant reminder of a pain and a struggle that is something that they just long to forget.
yeah,
And when someone is kind of contending with that, I don't think that there's any one measure that will ever get rid of all of that discomfort
yeah,
because all the newest modalities, whether it be, a laser treatment for a pigment issue, whether it be, um, one of the many other features in terms of things that we can do from a regenerative standpoint to kind of even the overall tone and appearance of these things, they um they will still see them.
yeah,
And that's a personal struggle that I think a lot of women unfortunately contend with. And
yeah,
I think, the one of the reasons why I think this is important, I think that, I enjoy doing this element of it is that any little measure of improvement for those patients that we can actually achieve some element of healing for them and maybe make that burden just a little bit less, I think is that much better. Can't see my hands are off screen, but it's pretty big. Yeah.
I I like how you stated that. That was very well stated. One thing I didn't ask you about that I wanted to in terms of the whole healing process after surgery. What about physical therapy? That's something that I failed to ask you about, but I had it in my notes here. I wanted to ask you real quick.
Oh, sure, sure. So, as I stated, scarring doesn't happen in one plane. It's not just in the skin, it's down and it gets deep. That that area of scarring doesn't just affect the area between the skin and the fat, but it can actually go down to the connective tissue, to the fascia, to the muscles, to all the other functional elements.
Mhm.
The scar itself can affect nerves, can compress nerves. And so these sort of roots of the scar that can grow in multiple different ways can have effects that aren't readily apparent at the skin surface. And
Mhm.
so I think having physical therapy involved is a great adjunct if we're worried about that scar tissue limiting someone's ability to move or feel or actually have the ability to not have feelings such as pain,
Mhm.
or even have scarring in their deeper tissue that leads to fluid collections because
Mm.
of essentially pinching off their lymphatics and other things along those lines. So I think physical therapy plays an important role in how we can remodel those deeper areas.
Mhm.
The physical movement and the massaging of tissue during that remodeling phase is an important component of how we can affect that scar maturation in those deeper levels.
Mhm. Wow, so much covered on scars today. I just want to remind listeners that we're talking about scars with Dr. Andrew Gassman of PRMA in San Antonio. So, as I always say, listen to the video, listen to the podcast, get out your pen, paper, whatever, hit the pause button, take notes, because these are all great things that you can talk to your plastic reconstructive surgeon about. We hope there were some surgeons who listened in. Maybe they'll think about some of the techniques that you talked about, Dr. Gassman. Um, I think that what you shared with us today is very valuable and important. So thanks for your time. I appreciate it.
Oh, my pleasure.
And really great to see you. Thanks.